This patient has varicose veins affecting the medial aspect of the right leg and into the popliteal fossa. We're planning to treat her with foam sclerotherapy. First of all, a clinical examination to look at the distribution of the veins and to assess which is the source of the problem. Next, we're going to do some ultrasound imaging to identify whether or not the great saphenous vein is competent. The vein is insonated near the knee in order to identify the source of the varicose veins. Blue and red flow in the great saphenous vein show that the vein is incompetent and causing the varicose veins further down in the leg. The next stage is to confirm exactly where the varices join to the great saphenous vein. In this case, all the varicose veins arise in the region of the knee in a major accessory vein. The patient lies comfortably on the bed while we inject a little local anesthetic and introduce an 18-gauge intravenous cannula into the great saphenous vein. This is readily done under ultrasound guidance. The cannula is secured with tape and flushed to ensure that the tip of the cannula lies in the lumen of the vein. The same process is repeated for several further cannulas. In this case, 2 have been placed in the great saphenous vein in the thigh, and a further smaller blue cannula has been placed into a superficial accessory vein. All cannulas are checked for proper function by injecting saline. The final cannula is placed just above the ankle in the great saphenous vein. Here I'm using a 20-gauge cannula, which is small enough for even the tiniest saphenous vein. The first thing I'll do is flush the vein with saline, to which we've added a small amount of adrenaline. Here we've elevated the legs to facilitate the next part of the treatment. Elevating the legs minimizes the amount of blood remaining in the saphenous veins. The first stage is to flush the veins with saline to minimize the amount of blood that is still retained within the saphenous trunk. Some 0.5% fibrovein foam is prepared using the Tessari technique. 5 ml of foam is sufficient to treat the great saphenous vein in the calf, so it is divided between the 2 most distal cannulas. Further foam is made in order to treat the great saphenous vein in the thigh. Here I'm injecting 3% fibrovein foam to ensure permanent obliteration of the great saphenous vein in the thigh. I usually use 10 ml of 3% fibrovein to treat the great saphenous vein in the thigh. I'm re-injecting more foam into the same vein to ensure permanent obliteration of the vein. Finally, a short stretch bandage is applied to the leg to minimize the amount of bruising and the amount of blood retained in the successfully treated veins. The bandage I'm using here is Pierhaft, made by Hartmann, and it is a very effective compression bandage. The bandage is secured by adhesive tape to make sure that it doesn't slide down the leg. The bandage is covered with a Class 2 medical compression stocking and will remain in place for 1 week following the treatment. The patient can remove this bandage themselves. Immediately at the end of treatment, the patient can leave the treatment room. In another patient, ultrasound-guided foam sclerotherapy had been undertaken 2 weeks previously. Some thrombus had accumulated in the successfully treated veins and was causing the patient discomfort in the region of the calf. The skin is anaesthetized with an injection of local anesthetic and a large bore needle used to aspirate the thrombus. This is repeated at various levels in the calf until all the thrombus has been retained. The effect of this treatment is to speed resolution of the successfully treated veins, avoid lumps and thrombophlebitis, as well as make the treatment more comfortable for the patient. A further patient has undergone previous varicose vein surgery and now has some recurrent varices over the thigh. There is no problem with the saphenous vein in this part of the leg, so we don't need to treat that. And then what I think all we need to do is a direct injection. The varices arise in residual superficial accessory veins, which have been left following previous surgery. Some lateral varices in the popliteal fossa are very small in diameter. They're not associated with the lateral popliteal fossa perforating vein. The varices are traced upward and arise in the anterior accessory great saphenous vein. In this case, because the varices lie in superficial tributaries, direct needle injection of the varices is used. This is effective in managing smaller, more convoluted varices remaining after previous surgery. I start proximally and gradually work down the leg towards the ankle, injecting all the veins over one aspect of the leg as I go. On this occasion, the more important varices lie over the medial aspect of the thigh and calf, so I started with this part of the leg. The patient also has some smaller reticular varices over her shin, so I'm using liquid sclerosants to inject these. I normally use 0.1% fibrovein liquid for this purpose. The varices in the popliteal fossa are injected as well, but they are in fact reticular veins rather than saphenous varices. Inject about 1/4 ml of solution into that is sufficient. And then we can put this on the foot. The treatment is completed by application of a Class 2 medical compression stocking. The patient will wear this during the day for 3 to 7 days. In this patient, who has already completed a course of foam sclerotherapy, one last residual varicose vein is injected with a small amount of foam under ultrasound guidance. Following that, the ankle telangiectasies are injected. 0.1% STS liquid is used for this, and not more than 1/4 of 1 ml is injected at any one place. Using this technique, many ankle telangiectasies can be treated effectively in a single session. The treatment is concluded by application of a Class 2 medical compression stocking, which is worn for 3 to 7 days during the day, but removed at night.
Sclerotherapy is a well-established medical procedure for the treatment of varicose veins, reticular veins, spider veins and telangiectasia. Tiny needles are used to inject small amounts of sclerosant into the troublesome vein, which is irritating to the vessel wall, causing it to collapse and stick together. Sclerotherapy is the gold standard treatment for smaller unsightly veins and is a treatment option for larger veins. Loops, vein light or ultrasound Doppler may be used to help identify the veins to be treated. Compression is usually applied afterwards, and treatment should only take place after a full consultation when medical history, consent, aftercare advice, risks and benefits of the procedure will be fully explained. The British Association of Sclerotherapists is a not-for-profit organisation that was established in 2003 for the benefit of its members and to provide education and support to raise and maintain standards, promote evidence-based practice in a clinical setting and as a vital source of information to the public and media.
A diagnosis of idiopathic leg telangiectasia is based on a history, examination, and appropriate special investigations. Expert consensus agrees that sclerotherapy is the most effective treatment. Now, sclerotherapy is a medical intervention, that is, the intravenous injection of a prescription-only medicine for the treatment of C1 venous disease. It is undertaken by trained and competent healthcare professionals in a clinical environment. The correct dose and strength of the licensed sclerosant is double-checked, and it is injected into the telangiectasia with the aid of magnification and illumination. The telangiectasia are cannulated directly using a 30-gauge needle, and success is indicated by the blanching of the vessels. The injecting hand is stabilized on the patient, and the non-dominant hand stretches the skin flat. The needle trajectory is very flat against the skin, so on occasion it is helpful to bend the needle to 30 degrees. Fortunately, serious complications are extremely rare, but healthcare professionals providing sclerotherapy must have the necessary trained assistance, resuscitation equipment, and medication available to take immediate action to deal with rare and unexpected emergencies. Now, the most common adverse event is extravasation of sclerosant, which results in a bleb. Provided a bleb is recognized early and injection is stopped immediately, small blebs are of no consequence. However, any sclerosant of any strength, if injected in sufficient quantity, can result in skin breakdown.
This patient has varicose veins arising from the great saphenous vein. We start by introducing intravenous cannulas into the saphenous trunk. I inject a small amount of local anaesthetic into the skin, through which I place an 18-gauge intravenous cannula in the proximal part of the saphenous vein in the upper thigh. The cannula is flushed to check that the end of the cannula is safely within the vein, and the procedure is repeated at the lower part of the thigh and later in the calf. Eventually 4 cannulas are present in the great saphenous vein, and that will effectively fill the entire trunk with sclerosant foam. The next stage is to inject any tributaries. Under ultrasound guidance, I'm injecting some dilute foam into some superficial varices which are filling telangiectasies. In order to foam the saphenous trunk, we elevate the leg to encourage blood to leave the saphenous vein and flush the vein with saline. Now I'm injecting sclerosant foam along the entire length of the saphenous trunk. I use stronger foam in the thigh than in the calf. Finally, a short stretch bandage is applied to the leg. This will remain in place for 1 week after the treatment. The bandage is secured with adhesive tape to ensure that it doesn't slide down the leg. Finally, a Class 2 medical compression stocking is applied to the leg. This will ensure that the bandage remains in place.
So what we do next time is see how
the patient can then resume normal activities.
human.
Yes, I do.
And then I compress.
The next stage is to inject the reticular varices and telangiectasies. Some reticular varices are clearly visible over the front of the shin, and here these are being injected with polydocanol.
So these are the big blue wobbly things. The big blue veins tend to encourage the development of thread veins.
So busy all the time. And she just
In the region of the ankle, there are several telangiectasies, and these can readily be injected under visual control.
Anyway, I found a vein to inject by the stretch.
I don't know why I did that because
A small superficial saphenous tributary, 1 mm diameter, has been identified, and this is injected under ultrasound guidance. A Class 2 medical compression stocking is applied, and this is going to be worn for 3 to 7 days during the day.